rhythms unless it gets a little out of control and starts going real fast. And then we're going to hear about atrial tachycardias and supraventricular tachycardias and stuff like that. So we're talking about an impulse that's originating somewhere in the atrium outside of the SA node, and then it works its way through in a normal manner. Okay, so I'm going to go ahead a little bit. We talked about all of this. Okay, so the first one that somebody liked before was the WAP, right? The wandering atrial pacemaker. So if we go across and look at it, this complex, pretty much P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, T wave. But now we start having P waves that start looking a little differently. So what they're saying here is that the SA node is not firing. Random places in the atrium are taking over as the pacemaker site. Okay, so there's only two different P waves. So this might actually be SA node. It's not very pointy, so this might actually be SA node. But these are someplace in the clinically not significant. Okay, the only way you'd know is if you really did a good looking at the EKG and noticed that the P waves were different. Other than that, it's going to look totally normal. The only, I'd say, variation for this is if the heart rate goes above 100, then instead of calling it wandering atrial pacemaker, we call it multifocal atrial tachycardia, only because the heart rate's above 100. Okay, there they can be a little more symptomatic just because the heart rate's increasing and stuff like that. Okay, the next thing that we could have is premature atrial contractions, or PACs. So premature means that it happened earlier than we thought. Okay, that's all it means. So this is that the person's typically in a normal sinus rhythm, and then what happens? That someplace in the atrium doesn't wait its turn. Before the SA node was going to fire, somebody jumped ahead in the atrium and fired. So now what it's going to be is it looks exactly like the SA node complex, happens earlier, and the P wave is going to be a little different as far as the P wave goes because it's not going to be a rounded P wave. So let's look, over here. So what it's saying is that instead of the SA node firing, someplace in one of the atriums fires ahead of time. So you have normal, 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 and then what happened? You had one that happened earlier. Okay? So that complex could generate a pulse, could not generate a pulse. Okay? That's the first thing. Just because it electrically fires doesn't mean that it's actually causing mechanical contraction. So what you're going to see here, they have terms compensatory pause and non-compensatory pause. Don't worry about it. What we really care about is, did the complex generate a pulse or not, right? In other words, is it helping to keep the patient awake and alive, or is it not helping to keep the patient alive? If it just electrically fires and doesn't generate a pulse, it's obviously going to slow down the heart rate, because after that PAC fired, the heart still has to relax and get ready for the next one, right? So you would like if the PACs actually generated pulses. Now all it's saying to you is that the person's getting older, and the SA node's getting a little tired, the atrium's getting a little irritable, and every so often the inside of the atrium fires. There's no real clinical significance of a PAC. But what the patient may say to you is, what? They call you to the house, and what's going to be their complaint when you walk in the door? You're going to say, sir, what's the problem today? If it goes fast, it may be, but the skip beat, or I feel like my heart's irregular, I feel like I'm having an extra beat. They may feel that sensation, they may feel that pause. Okay, or they may feel the extra beat. Palpitations usually means the heart rate's going real fast and they feel that fast pounding sensation. But they're going to basically describe to you some type of, feeling like they're having that extra beat. You're going to put them on the monitor. You're going to see they're in a sinus rhythm, and you're going to see they have an earlier beat than normal. Now, can you make out, okay, that the beat, the P wave of this beat, okay, well, actually, the way they drew it, it kind of looks like all the other ones, but it should technically look a little bit different, okay, than all the other ones. So hopefully we'll have a few other ones where it is. So that's all it is that someplace in the atrium fired earlier than normal than it was supposed to, okay? So slightly diseased conduction system, no big emergency, okay?
Or too much caffeine.
Could be, sure. Could absolutely be. I have a guy that I work with that if he, the good joke on him is to switch to caffeinated and decaffeinated coffee. If you don't want him to come to the meeting, he's one of these guys that talks forever in a meeting. So you switch the coffee around, okay? And if you give him caffeinated coffee, he starts throwing PACs like crazy, and he runs and puts himself on the monitor so you can cut the meeting down real short, you know? So the next time, Bob, next time he comes to teach you about the software program, the billing program, you can give him caffeinated beverages. And you can. Okay, so here's a normal, and what happened? Had an early one, but it keeps on happening. You see what's happening here? In other words, this is where, so if you follow this one to this one, the next one should really be like right over here, but this one happened early, and what do you notice about the P wave? Pointy, right? So that's something that happens somewhere in the atrium, outside of the SA node. Now, this is an interesting one, because this is called PACs with bigeminy. Bi means two. So it's happening every other, right, after every complex you're having one. So this is showing you that's, you know, something a little more is going on than just once in a while. So this patient probably does feel, you know, now, if these were non-compensatory, these were not generating a pulse, what would this patient's heart rate be? 1, 2, 3, 4, 40? Yeah. So they feel what? Weak and dizzy. So that's why, remember I said the most important thing is to find out, are those extra beats conducting and making a mechanical contraction? Because you're talking the difference between having 1, 2, 3, 4, 5, 6, 2, 4, 6, 70, heart rate of 70 or a heart rate of 40. So obviously the patient's mental status is going to be greatly different depending on what their heart rate is. So that's the more important thing, is, you know, are these impulses conducting? Okay, so that's called atrial bigeminy, to having a PAC every other beat. Trigeminy would be, we can't see it here, but let's say there's 2 normal beats and then 1 extra beat, 2 normal beats, 1 extra beat, that would be trigeminy. Okay, so then it becomes a little more concerning to us, you know, why they're having it. Only, again, they would only be symptomatic if those extra beats, if those premature beats were not generating a mechanical contraction of the heart. Okay. So caffeine, alcohol, hypoxia, increased sympathetic tone. So in other words, this is a irritable atrium firing before it should. It's like a misbehaving part of the atrium firing. So these are all different reasons, electrolyte imbalances and stuff like that. So if you're having more than 6 a minute, we talk about it being frequent, okay? And as if it's explainable, you know, caffeine, okay, nervousness, something like that, not a big deal. You just reverse what it is. If it's not explainable, it could be that they have an irritable foci. They have like one part of their heart that's irritable, and every so often just misbehaves. And then what they have to do is go in and burn out that little piece of the heart, the tissue. They do something called an ablation. So if you have like one part of your heart that just doesn't behave, sometimes randomly starts firing, okay, puts you into tachycardias and stuff like that, they can do a procedure called an ablation, and they'll go in, they'll put you in an electrophysiology lab, they'll actually cause the heart to do that, they'll see where it's firing from, and they'll bring these little tiny wires, they put a little electrical current, like heat, okay, and it'll burn out that section. And that will cure the issue. It is always possible, if you're really unlucky, that it could grow back, okay? Like you can't get rid of it, you know, it comes back. But most of the times when people have an ablation, it deals with their tachycardias, ends their tachycardias, they don't have to be on medications anymore or anything like that. So.
Right. What's increased
sympathetic tone is adrenaline. So anything that you do to increase your sympathetic nervous system, okay, could make your heart fire earlier. Like in other words, caffeine does what? Caffeine stimulates your sympathetic nervous system, right? So when you drink caffeine, you don't notice it, but your level of awareness goes up a little bit, okay? Your vision improves a little bit, right? So I mean, actually in the military, before they go out on a patrol, they'll give them caffeine pills, okay? Because it's a good way of increasing their level of alertness without it being addictive, you know, or very addictive, although some people that are pretty addicted to coffee, but, you know, very, very addictive and stuff like that. So, you know, so basically caffeine stimulates your sympathetic nervous system. So everything that happens when your sympathetic nervous system is stimulated will happen from caffeine, okay? Okay, so the reentry dysrhythmias. So now we're going to start talking about where impulses originate and take over and make the heart start beating very, very fast, okay? So they kind of, here they use the term short circuit the electrical system. So they basically take over the conduction system and run out of control, and the person goes into a tachycardia, okay? So this is what winds up happening. So if we look over here, the first thing we notice that this is a pretty fast heart rhythm, right? So if we do 300, 150, So this heart rate is probably what? Between 175, going towards 200, right? So very fast. If you count it all the way across, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So heart rate around 180. So it's pretty fast, right? But it's narrow. Now the other thing you notice is that when it gets real fast, is it very easy to pick out the P waves. Everything that kind of gets mushed together, okay? But the QRS itself is pretty narrow, so we know that it's a rhythm that started above the ventricles. So this would be called a supraventricular tachycardia. Supra means above the ventricles. Some people will call this an atrial tachycardia, okay? But whatever it is, it's a rhythm. It's not a ventricular rhythm because the QRS is narrow. Now, what they're trying to say here is that this is caused by the conduction system getting a little out of control. Okay, now what's happening is that they get what's called a unilateral block somewhere in their conduction system. So look what happens. The impulse comes down, okay? Now, I know when we look at the EKG, it looks like it's like everything going one way, like one straight wire going away. But you got to remember, those wires are branching out and branching out and branching out, right? Those Purkinje fibers, are branching out like roots of a tree all over the place. So what they're showing you here is that it comes down and then it was going to branch out. But as it comes down this pathway, there's a unilateral block. What it means is that it didn't let the impulse come down this way, okay? But yet, when it comes back around, it's letting it. So what should really happen is that both impulses should come down here and go in their merry way and continue depolarizing heart muscle, right? Here, it comes down, goes like it should, but as it comes back around, it hits here, and for some reason it could go through the block, okay? This area, if it had been depolarized, would be used up, right? In other words, once an impulse, electricity travels through tissue, that tissue is used. It has to rest again before it can contract, right? That's the repolarization. But what happened here is that since that impulse stopped here, this never got depolarized. As it travels back up, it's fresh, so it allows it to depolarize. It goes back up and then it comes back down, goes back up, comes back around, and what happens to the heart rate now? Goes out of control, okay? It starts speeding up and going out of control until we figure out a way of terminating it or interrupting it. Now we can interrupt it with electricity, like cardioverting them, defibrillating them. We can interrupt it with certain drugs. I don't know if you've heard of a drug called adenosine. Okay, so that's a drug that sometimes interrupts it. What's that? 6, 12, and 12? Okay, so it used to be 6, 12, and 12. It used to be 3 doses. First one was 6, second one was 12, third one was 12, but now it's only 6 and 12, only 2 doses. But we'll talk about it when we get to it. But anyway, this is one of the things that happen. Are we ever going to know in 1,000 that this is what's actually happening in the heart? No. Okay, but they're just trying to explain how the rhythm could get out. So it really just comes down to that it's finding fresh heart tissue that has not been depolarized and taking advantage of it. That's really what it is. Okay, and that a PAC could be the cause of happening all of this. Okay, that the PAC could be the thing that triggers all this to kind of fire and happen. Okay, so there's a lot of different reasons why people can go and have these reentry dysrhythmias. Okay, most of the times it's none of the reasons here. Most of the times it's they have what's called an accessory pathway. The normal pathways, we know, SA node, AV node, those are normals. Some people grow an extra pathway. Okay, it sits there dormant, okay, until what happens? So picture you have, it's coming down like it should, but you also have this other pathway, right? So it fires like it should, goes down the normal pathway. Everything above it has been depolarized. Nothing's going to make it work until it repolarizes. But now you have a PAC. Somebody jumps and fires early. The PAC tries to go down a normal pathway. What does it say? It won't work. The other pathway, fresh. So now it goes down the other pathway, and if it wraps back up and starts coming around, you get this circus dysrhythmia, and you get this reentry phenomenon, and they go into a really fast heart rate. You will not know it looking at the EKG. This is something that they will find in an electrophysiology lab. Makes no clinical significance to us why it happens. It only just matters what happens, which is the heart starts beating very quick. And we know when the heart starts beating very quick, the blood pressure drops because of the ventricular filling time. Is there any issues when you have a rhythm like this with the atriums not contracting? No. Atriums are probably contracting. The problem here is the ventricles are not filling with blood because the heart rate is so fast. The other thing is, how much oxygen does the heart tissue itself need if the heart rate is 180? More, right? More than it would need if the heart rate is 150. or 100. And if the ventricles are not filling completely, then you're not going to be pushing as much blood, so you're not going to get enough oxygenated blood. So that's the danger of this. Now, you can get some people that go into these rhythms, and they could actually break it themselves. How do they break it themselves? They bear down, they do these different procedures, okay, but sometimes it doesn't work, and sometimes we have to come and treat them. Eventually, if this happens enough times, they're going to get a Holter monitor put on them, okay? They're going to see it on the Holter monitor, right? A Holter monitor is just an EKG they wear around that they could download, 3 days, 5 days worth of EKGs. They're going to see it happen, okay? And then they're going to refer them to a Westchester or a Columbia, to an electrophysiology lab, okay? You go, you lay down at a table, they give you some Versed, mail you out, and then they actually stimulate your heart, okay, to do it. So they bring a catheter all the way up to your heart, and they start touching all parts inside of your heart to see if they can get it to do crazy things. And then they map it, okay, and find out where these irritable areas are, what these accessory pathways are, and then they burn them out, and they do an ablation. Okay, so that's basically what it is. So now we're going to talk about some of the rhythms. So we had the atrial tachycardia, okay, which would be this one over here. Now we have another one called atrial flutter. Okay, so flutter is a very, very interesting one, where what you're going to see is a sawtooth pattern. Okay, these are actually the P waves. One of these might actually be the T waves. I don't know, but these two over here are more like P waves. They take a very triangular, like a shark tooth or a sawtooth on a saw type of pattern. So what's happening here is that there's, again, certain parts of the heart that are firing, and how fast the heart rate depends. So you could have atrial flutter where if every flutter wave contracted through, so right now this heart rate is 1, 2, 3, 4, 5, 6, 7, 8. And let's say there's 2 flutter waves in front of every one. So it's 80. That means only one is conducting. If both of them conducted, the heart rate would double. So it would go to 160. If these are 3 flutter waves, then you're going to add another 80 to the 160, right? So then you'd have 240. So it depends on how many waves actually conduct through to the ventricle on how sick they are, okay? Not a common rhythm, atrial flutter, happens, okay? But this is definitely the patient who may call you and say, I feel like I'm having palpitations, if the heart rate starts to increase. The classic is the sawtooth pattern, is that you would see. Now, if this rate was faster, would you see the sawtooth as well? Remember, as the rate increases, what happens? Everything in between gets mushed together, and it's harder to see it. So this is a nice slow one, and you're able to see it. But as it would get faster, it would be harder to see. So somebody in atrial flutter that's stable would be taken to the hospital. Nothing would be done for them. Somebody who's in atrial flutter, okay, and unstable, then we might have to intervene. If they're really unstable, again, electricity is your tool of choice. When you shock the heart, what do you do to the heart? Reset it, right? But we don't want to shock somebody because there's always potential. When you shock someone, what could you do to them? Kill them, right? You could put them in asystole. When you shock the heart, you stop the heart. There's no guarantee it's going to start up again. So most people are very leery. If this guy's talking to you saying, Frank, I feel like my heart's beating out of control, I can't catch my breath, he's still talking to you. So you're not going to probably cardiovert him because who knows what could happen, right? So you're probably going to try drugs. Now, adenosine, the drug we talked about before, would not be very effective in this. But sometimes we use it diagnostically, which means when we give adenosine, it may transiently slow it down. So if it was all mushed together and you couldn't see it, you give the adenosine, it slows it down for, say, 60 seconds. You see the flutter waves, and you say, oh, it's atrial flutter. I know adenosine's not going to work on that. And then you would give them a drug called cardizem. Okay? And that would be a good drug to treat that with. Okay? So there's a lot of different reasons why people go into flutter, okay? Again, typically older people, but anybody at any age can go into flutter. It's again, you would treat the rhythm, you treat the patient, not the rhythm, so how they're tolerating it. Now, atrial fibrillation is another abnormal atrial rhythm, okay? So here we're talking about, again, SA node, not the dominant pacemaker, someplace in the atrium is firing, right? So now you have these fibrillatory waves. So instead of calling them P waves, we call them F waves, these fibrillatory waves. And by definition on the test, this is going to be an irregular rhythm, which means there's no atrial regularity and there's no ventricular regularity. So basically you're having hundreds of foci firing in the atrium, okay, and only one gets down to the ventricle. If they all did, the heart rate would be 500, right? But only one is getting down, okay? But it's rhyme or reason which one gets down each time, which means that the QRS firing there's no regularity to it. So you're going to have no atrial activity that makes any sense, and then the R to R's, the difference between the QRS's is totally irregular. Okay, so let's take a look at it. So what do you got? So a lot of squiggly lines where the P wave should be. You probably have a T wave, right? So the bigger line is the T wave. Okay, but you got a lot of squiggly lines. And if you took out your calibers and you mapped out the R to R's, okay, are they regular? No. But why can't this be artifact with PACs? And the answer is it could be, right? Why can't you just have somebody shaking, okay, which is what's screwing up the flat line there? And the reason it's irregular is somebody's throwing some PACs. Why can't it be that, this is all normal? Maybe even this one. Well, this one's a little late, but I'm trying to find
Fifth one over.
Yeah, whatever. I'm just saying, why can't it be that, this is just all normal, and then there's, this one's extra or something like that. So that's the danger of only looking at a short strip when you're making a diagnosis, right? You want to look at the thing running so you could see, am I only looking at something that's happening for 6 seconds, or am I looking at something that's happening throughout the patient's EKG? And, there's no way of knowing. I'll just tell you that if you thought this was artifact, then what are you going to do? You're going to pull the ambulance over to the side of the road. You're going to have the patient sit still, okay? You're going to press on the electrodes, make sure they're adhering to the chest. If the patient's really hairy, shave them a little bit, put on fresh electrodes. There's ways you could rule out artifact. And again, with the newer monitors, they're going to say to you artifact. So you'll know, okay? Remember, the newer monitors are looking to interpret this. And if they're not getting a clear tracing, they're going to say to you, I can't get a clear tracing because of artifact. And for it to make an interpretation, okay, one, it'll only make an interpretation if you do a 12 lead, which means you have all 12, you have the V leads on. The other thing is you have to say whether it's male or female. You have to input into the computer male or female and the age of the patient. Because remember I said it takes different parameters to diagnose. So it needs to know male or female, okay, and the age of the patient to make a best guess at what they think the rhythm is. Okay, so what causes atrial fibrillation? Okay, most of the times it's old age. Okay, most of the times it's just that your conduction system is getting old. Rheumatic fever does have a little bit of so if you have rheumatic fever as a child, you're prone to two things later in life: atrial fibrillation and what's mitral valve prolapse, right, or mitral valve disease. There are two things you're prone to later in life from rheumatic fever. Not every single person who gets rheumatic fever is going to get either one of those, but just statistically they have a little more of a rate than people who did not have rheumatic fever. Okay, so again, it's old age, it's disease of the heart and stuff like that typically causes it. Okay, stress can bring out atrial fibrillation. So you can go to somebody's house and they can say something to you like, I had a classic one the other day. So the guy's daughter is getting married. Okay, and it was right up to the last minute, a couple days to the wedding. He said he hasn't been sleeping, and now he feels like his EKGs, his heart rate's all over the place. We put him on a thing, and he's in atrial fibrillation. So, do you have anything wrong with your heart? No. Do you have any abnormal rhythms? No. Well, you do now, right? And the stress is an explainable thing. So now the problem is that that's called a nuanced AFib. So now you're concerned he's not anticoagulated, right? So you don't really want to play around with the rhythm. You want to get him to the hospital. So before they try to, quote, reset the heart, they're going to try to figure out when did it start. If it started 5 minutes before they called us, he didn't have time to develop clots. They can try to reset his heart and get him out of the AFib. If he says to you it's been happening on and off for 5 days, the chances are he may have developed some clots. So there they have to anticoagulate him before they try to reset his heart. Okay, my father-in-law had to have shoulder surgery. Didn't seem like it fazed him or anything like that. Take him down to Columbia. We do the admission. The anesthesiologist is checking him out before the surgery. They put him up on the monitor, and I look up and he's an AFib. So I look down because they're going to scrub the surgery if they see he's an AFib. So I'm hoping that the anesthesiologist will not look at the monitor. Figure, And everything's fine, Mr. Zuckerman, you're going to be fine. He signs all the papers. He starts walking out, and over his shoulder he looks up at the monitor. I guess he got to the box on the piece of paper where we had to write the rhythm, and he goes. Oh, we have a problem, Mike. Another day I'm going to miss from work, right? So they scrub the surgery. So his AFib is totally stress related. It could be the littlest stress and it brings out AFib. And that is a common thing. And it'll even happen in college age kids like final exam week. Okay? They'll be all stressed and stuff like that, and they can go into AFib. So they're going to say to you, I feel like my heart is not in a normal rhythm. Okay? Now if they pop in and out of it, and it goes away, maybe they're in it for a half hour and it goes away, Should they get looked at by a cardiologist? Yes. They may be put on a beta blocker to kind of slow down their heart rate and stuff like that, but it's explainable. You know, it's the ones that are in prolonged AFib are the ones that run the danger of developing clots and stuff like that. You know, and that's the real big danger of it. So my father-in-law's case, what they actually had to do, because every time he went for surgery, he would get nervous and have this, is they actually brought in an anesthesiologist that was the anesthesiologist at open heart surgery cases. And he had a much higher comfort level in taking care of sick people. And he was like, hey, fib, and put them right to sleep, and they did the shoulder surgery. So it's just a difference. In other words, the run-of-the-mill anesthesiologist that was doing outpatient shoulder surgery, he didn't want to mess around with anything that wasn't perfect, where you get a guy who's, you know, taking care of sick patients on a regular basis and keeping them asleep. He was like, don't worry about it. You know, and boom, they did the surgery, and, you know, he was fine. So that's just the difference in what happened. So again, here, atrial fibrillation, typically, the drug we would use is cardizem, ditalazem. It's a calcium channel blocker. Okay, so it's another type of medicine that's used for two things, treating blood pressure. Calcium channel blockers to do blood pressure, relax the blood vessels, and that's how you lower the blood pressure. But calcium channel blockers actually interfere with the traveling of the complex through the AV node. It slows it down a little more. So by slowing it down a little more, it slows the heart rate. So it's a good drug. Somebody just mentioned and showed me an EKG on the break where they had a lady that was symptomatic from a bradycardia, and the medic did a good job of assessing the patient and asked about medications, and she was on a calcium channel blocker, probably cardizem. It's the most widely prescribed one. Okay, and she took too much of it. Okay, and that's why she was bradycardic, because it's supposed to slow down the heart rate. If you take too much of it, it slows down the heart rate too much. Or it could just be the doctor picks a number. Let me try, you know, and she's, you know, she weighs 160 pounds. So instead of giving her 2.5 milligrams to start with, I'm going to give her 5. And 5 turns out to be too much. Now, she's not going to have symptoms in the doctor's office. She's not going to have symptoms the first day she takes it. She's only going to starts having symptoms when? The second or third day, because that's when she builds up a therapeutic level. Now she feels all weak and dizzy, and she calls us, and we find her in a normal sinus bradycardia. And what should we ask her? Have you been put on any new medicines? Have you changed your dose of any of your medications? And we're going to find out it's the calcium channel blocker, because she's going to tell us 3 days ago I was put on this medication, and you can put 2 and 2 together. How do you think we treat a patient? So if it's a drug that says a beta blocker, calcium channel blocker, if it's ever an overdose, if something has the word blocker, how do you treat it? You give what it's designed to block. So in other words, if it's a calcium channell blocker, give them more calcium. If it's a beta blocker, give them a positive beta drug, epi, right? So whatever the block, and I mean, again, this is with training and moderation, but whatever the blocking agent is, if they're symptomatic, you give them whatever, you know, is designed to its block, and that's how you treat them. Because they're all called competitive antagonists, which means that if you give them enough, if you give them what they're designed to block enough of it, it'll reverse it. Okay, so now we're going to get into one that could be, you know, I mean, these are dangerous but not typically life-threatening, but supraventricular tachycardia, okay? So by definition, okay, it's a heart rate above 100, but by real definition, it's an atrial rhythm, a supraventricular rhythm, over 150 or 160, above sinus tachycardia, okay? So again, what's the danger here? The danger here is that the decreased ventricular filling time. The danger here is the stress on the heart, the workload on the heart, okay? So they may call it paroxysmal supraventricular tachycardia, or all paroxysmal means is that the patient's going to say to you, I was just sitting here and it started. And maybe before you got here, it stopped. Or sometimes it doesn't stop. But in other words, it's sudden onset and maybe a sudden stopping. There's no reason why they went into it. Although, I've had people who said, I ran for the train, and my heart was pounding, and I took the train all the way up from New York City, and it's still pounding. Okay, so that would not be normal if they were sitting on a train for a half hour. Even if they, you know, they were tacky because they ran for the train, it should slow down before they, you know, get up to suffering, because they had an hour on the train. So if they're still in it, it probably means now that it's not just sinus tachycardia where the adrenaline from running is making the heart rate fast. Here it's that there's an abnormal part of their heart that's controlling the heart and making it beat fast. Okay? So you have an atrial ectopic focus. So we said foci is a little part of some part of the heart that's firing when it's not supposed to, right? It's misbehaving. Atrial means that it's in the atrium. Ectopic means outside of, like an ectopic pregnancy, outside of where it should be. Remember, an ectopic pregnancy is a pregnancy that fertilizes in the fallopian tube where it's supposed to, but gets stuck in the fallopian tube. The egg doesn't travel and fall into the uterus, and as it expands and grows, it could burst the fallopian tube and sever the fallopian artery and vein. So all ectopic means is that it's outside of the normal place, okay? So this foci in the atrium basically kicks out the SA node from becoming the dominant pacemaker and takes over. And it fires out of control because it's not going down the normal pathways like it should. Okay? So it can resemble a sinus tachycardia, except that the rate is real fast, and that you're not going to see P waves when the rate gets real fast. Not that they're not there, but they just get hidden and mushed together. Okay? So this would be a supraventricular tachycardia. Nobody would have any problem saying this is fast, right? But how do we know it's fast and above the ventricle versus fast and below the ventricle, right? How do we know the difference by the QRS width, right? Is this a narrow QRS or is this a wide QRS? Pretty narrow, right? So if we looked at it, it's 0.2 boxes, maybe a little bit of a third. So 0.8, this is 0.12, so it's somewhere right around 0.10, right? What do we got? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So who cares? It's already, past 180, right? So this is 200 plus. What is that patient going to say to you? I have palpitations. My heart is beating. I feel dizzy. This is why they dizzy, because they have that decreased ventricular filling time. They're not having a high enough cardiac output. Okay.
So, what would it tell this versus a standard sinus tachycardia? Just the numbers.
The numbers in a sinus tachycardia, we're out of the sinus rhythms, but in a sinus tachycardia, you see P, QRS, T, right? You see a clear.
Water, the faster it gets, the more motion not going to see it.
Right. So that's what I'm saying. But sinus tachycardia, because the rate's between 100 and 150, it's clearer to be able to see the P waves. Okay. So could you have sinus tachycardia that approaches 200? Yes, very rarely. 99% of the time in pediatric patients. Kids can have sinus tachycardia approaching 200, 220. Okay. Adults typically will not. The other thing would be history. Okay. If it's sinus tachycardia, what history would you hear versus SVT? The guy in SVT is easy. What's he going to say to you? I was sitting here, all of a sudden my heart went boom. Okay. Or I ran for the train, my heart started beating real fast, and an hour later it's still doing it. Okay? So it's a very distinct when it happened. The person who's in sinus tach, if they were scared, they're going to say to you, something frightened me. If they were dehydrated, what are they going to say? I had vomiting and diarrhea for 3 days. Okay? In other words, if it's compensatory, you're going to be able to hear in history that's telling you why it's compensatory. Okay? So a lot of times history plays a role, not just looking at the EKG. Okay? So here's sinus tach, but a little slower, right? So here's this. This one is going to be only about what? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So 170. So this is now a borderline, okay? Could be sinus tach, could be SVT. But if we just went by the fact that we see no P waves, okay, we would probably call it SVT versus sinus tachycardia, because if you see P waves, you would be more towards calling it sinus tachycardia. Okay? So what causes SVT? Again, most of the times, it's an accessory pathway. How do we treat it? You could try vagal maneuvers, okay, bearing down, coughing, squatting, carotid sinus massage, or again, 99% of the time, we use a drug called adenosine. Okay? It's a very quick, effective way of treating it. Okay?
Frank, what is the SHD?
What's this? Atherosclerotic heart disease. Okay, so it's basically you have two types of. The easiest thing is just say CAD, coronary artery disease, but you have ASTH, okay, and you have atherosclerotic and arthrosclerotic. So one is fat, one is calcium. Okay, the only way you would know is if you have a very special blood test called a calcium scoring test. Either way, it's not good. If you have fat on the inside of your arteries, they could always rupture and cause a heart attack, or it would just narrow the lumen. If you have calcium in your arteries, remember that the old term for angina was hardening of the arteries? When you get calcium in the arteries, they stop the arteries from dilating and constricting like they normally would. They stiffen them. So when you're running, you would want your coronary arteries to dilate so you get more blood to your heart. They can't dilate, so you get less blood to your heart, you get chest pain. The other one, you get less blood to your heart because of fat. So it's just a question of, what poison is called, in other words, what did you do? So, and believe it or not, the calcium problem is not caused by excessive calcium. It's not like because you increased the calcium in your diet that you got that. It's just totally the way the body's using the calcium. So it's, where you can cut down on fat in your arteries, changing your diet to low calcium just makes you more likely to have fractures. So, it's not going to prevent you from getting heart disease.
Hyperkalemia.
Hyperkalemia is high potassium. Okay, so that's another. We talked about the first class, right? We said electrolyte imbalances can be a cause of a lot of different rhythms. Okay, so hyperkalemia could be one of them. Even hypokalemia, low potassium, like somebody who's on a diuretic, okay, can have it. Or somebody, remember we said with the athletes, if they drink too much water when they're exercising, they're going to urinate out a lot, and they're going to urinate out potassium and sodium. So there's a lot of different reasons why they could have it. So SVT, if they're tolerating it and they're talking to us and they're awake, it's going to put an IV and take them to the hospital and watch them. Okay. If they're not tolerating it, we're going to try to vagal them. Okay. And if that doesn't work, give them adenosine. In all honesty, most people are not going to take somebody all the way to the hospital with a heart rate of whatever that guy was, 240. They're going to feel like, at any minute they're going to go from stable to unstable. So probably they're going to put an IV in them. Okay. They're going to try to have them do some type of vagal maneuver. Say 20-30% of the time that would be effective. And if that doesn't work, they're going to give them adenosine. Adenosine, I don't want to say is a benign drug, but it typically doesn't have any real bad side effects. It either works or doesn't work. It doesn't have any really bad side effects. So they probably would try to terminate it before they got to the hospital. Okay, but by definition, if they're totally stable, it would be an IV and a ride to the hospital. But, people typically don't like seeing somebody go with a heart rate that fast because you're afraid, you're going to look away at 1 minute, the next minute you look over to them and they're going to be unconscious because they're not perfusing their brain anymore because their blood pressure drops. So this is an interesting one. Doctors Wolff, Dr. Parkinson, and Dr. White, okay, back in the 1940s, figured out that people can go into tachycardias from an accessory pathway, from an extra bundle of tissue. Okay, so there's WPW, there's LGL, I think that was long, LG, long, I don't remember what the G was. I know the other L was Levine, long something, Gulang, Levine, were another 3 cardiologists. There's another rhythm. The most common one is WPW. So people know, they'll say to you, hey, by the way, I have WPW. And the average EMT would say, okay, because it's not something we typically talk about in EMT class. So I put it out there just to talk about it. Okay, so they have, an extra pathway, right? So we normally have one pathway. They have an extra pathway, just grew at birth, okay, laid dormant, and then all of a sudden at some point in their life, because they had a PAC, and that PAC couldn't go down the normal conduction pathways because it was used up, it decided to jump down those other pathways, and it sped through and started spinning around like we saw that circle, and threw the heart out of rhythm and stuff like that. Okay, so typically you're going to have some interesting things that happen. So what they're showing you here, okay, is that they have an accessory pathway that came from their left atrium down to their left ventricle. A very common but dangerous place to have an accessory pathway, because if you could jump from the left atrium to the left ventricle, right, and you make the left ventricle start to work before it's supposed to, it's very likely to put a patient in a tachycardia. Okay, so they're showing you what happened is that you see how it's going down and then wrapping back around and down and wrapping back around. So what's going to happen is it's going to make the heart rate go out of control. It's going to start spinning around and go out of control. Normally what should happen, it should go down and it should stop, right? The heart should depolarize, it should rest, and then you should have another complex. Because this accessory pathway is here and it typically is not used, it's able to go back up and then come back down. Because by the time it got back up here, what happened over here? It rested and repolarized. So it traveled through this little fake bridge, came back up and said, oh, it's all ready again, let me jump back down. Way before it's supposed to, and the heart starts to beat out of control. If they could figure that out, they bring a wire right up to here, they fry it, okay, melt it basically, and it doesn't happen anymore. Okay? These were the kids in school that fainted. So if you went to school with somebody that was always fainting or was, always passing out or something like that, they typically have WPW. Boom, all of a sudden that accessory pathway starts to fire. They go into a fast rhythm. They don't perfuse their brain. They faint. Okay, and sometimes even the hitting of the floor, what did it do? Reset them, when they did it. So, or these are kids you might have noticed in the middle of class. They're going, because they know they're in the tachycardia and they're trying to vagal themselves. Okay, so. This is what happens. Now, they have some very classic things. Typically, when you have a P wave, you have an isoelectric line, then you have a QRS, right? And this whole thing would be the PR interval. They don't have, okay, great slowing at the AV node because of the way this works. So they typically have a very short P to R interval, and they have this slurring. It's not a straight line like this, a 90 degree. They have this slurring up onto the QRS, which is called a delta wave. Great test answers, and when the rhythm is 200, do you see any of that?
No.
All mushed together. So doesn't really help us as far as our EKG. It's more of a test question and stuff like that. Okay. The other thing is, do you think the QRS is going to be narrow or wide if they have this kind of crazy depolarization? It's actually wide because, again, it could depolarize it outside of the normal pathways. Okay. So what do when they're going to do an ablation? They snake a catheter. Okay. It could be from your neck, okay, down through your superior vena cava. It could be from your wrist through your superior vena cava. It could be through your groin, through your inferior vena cava. But they basically float it all the way up the vascular into the right atrium, okay? And if it's on the right side, they'll go venous usually, and they'll be able to figure out. So they have some catheters that are actually looking at to track down the accessory pathways, so they're looking for the stimulation. And they have other ones that are the ablation ones that the heat comes out. So there's basically some doctor that deserves the $350,000 a year he's getting paid, who can actually manipulate all these wires. I'm talking like, hair-thin wires to where they need to go. They're obviously looking at an EKG and looking at a angiogram, picture, and they bring the wires all the way they need to go, and they fry out the area that's overstimulated. So actually that area kind of lights up. That one probe notices it, and you're like, aha, gotcha. And you bring the other one over there and you fry it. And then they actually try to stimulate them to see if it happens again. If it lights up again, they give them a little more until they fry it all out. On the left side, they may have to go atrial, okay, and then come in atrially. So they may have to go like into your radial artery and try to come in the left side through the atrial way, depending on where it is. So where they have to do the ablation. And there may be more than one, site that's firing. So they can do two things. They could burn out ectopic foci, which are sites that are acting up, and they could also burn out accessory pathways. So some people have one, some people have the other, or some people have both. Okay? So it really depends. Does anybody know of anyone who's had an ablation? So it's not uncommon. Yeah. You've had an ablation and it was successful the first time? No. So that's the other issue. Okay? So a small percentage, okay, are not successful. A small percentage are successful the first time, but it grows back and they need to have a second time. So, I guess it depends on, the skill of the person doing it. Did they get it all? How much it grows back and stuff like that. So, but, for the people that it is successful, it changes their life because they don't have to worry about it. Obviously, you always have this in the back of your mind that all of a sudden it's going to start firing and you're going to get dizzy and weak and stuff like that. Okay, so that's, again, we're not going to be able to pick up WPW typically looking at EKG. It's just going to look like SVT to us. The patient's just going to tell us they have a history of WPW. Years ago, before there was such a thing as ablations, they would actually have a sheet of paper from their cardiologist saying, this is John Smith, he has a history of WPW, and these are the things you should do to treat him. And they would give you basically a step-by-step treatment plan on that particular patient. Now, because there's ablations, you don't really need that anymore. They usually are able to deal with it that way. Okay, so we said wandering atrial pacemaker again was where there was what? It looks like a sinus rhythm, but there's P waves of different morphologies. Morphology means different shapes. So it's telling you that not only may the SA node be firing, but different sites inside the atrium. But the difference between wandering atrial pacemaker and having PACs is that wandering atrial pacemaker typically is regular, where when you're having PACs, those are early beats, premature atrial contractions. So those are early beats. This should be a normal rhythm, okay? Again, we had the premature atrial contractions, okay, which are that some foci in the atrium is firing earlier than normal, okay? Most of the times it's benign, there's nothing really to worry about, okay? But you do want to know that every one of those premature beats is conducting, right? Is actually contracting the heart. Okay, atrial flutter, now we're getting into ones that are a little more dangerous, okay? So atrial flutter, here you have multiple foci in the atrium firing, a very distinctive sawtooth pattern, and whether they're stable or unstable depends on their ventricular rate. So if their rate is over 100, 150, they're probably going to be unstable because of the decreased ventricular filling time, and they're going to need to be treated, okay? I mean, if you're in the middle of woods and someone, no medications, your guys are hiking, and somebody says to you, I feel like my heart's beating out of control and I feel a little weak and dizzy. Okay, so the first question you should say to yourself is what? Is the reason his heart rate beating fast is because he's hot and dehydrated? In that case, do we want to slow down his heart rate? No, because it's compensatory. What do we want to do? Cool them down and hydrate them. But let's say it's a beautiful autumn day, it's 60 degrees, you drank, you're not dehydrated, everything's wonderful, and this guy says to you, oh, I wonder if it's my heart. I have that problem every so often where my heart starts beating really fast. And you're in the middle of nowhere, and this guy says he can't go on any further. So what do? You got two choices. You leave him there, and you hike out, you bring people in, which, since I might be one of the guys that's to hike in and get him, I'll tell you don't do that. Okay? So what else do you do? You may tell them to bear down, right? What do you usually do? Does that ever help when you bear down or you do something like that? Maybe he can vagal himself, okay? Typically, vagaling on somebody who has SVT will do one of two things. Nothing or terminate the rhythm. Either it won't work or it'll terminate the rhythm. When vagaling is dangerous is you get these school-age kids that do it as like a joke to get lightheaded and dizzy. I don't know if you've heard of this, but they do all these different things, you know, run around, spin around. I was at the ball game the other day, and they had a contest where adults, okay, to win some chinchy prize, they basically would spin you around for like 3 minutes, and then whoever could walk 10 feet without collapsing got like, I mean, stupid prize. So the girl goes, do you want to go do it? And I said, no. You know, I said, there's only 200 people in the stands, but I really don't feel like making an idiot out of myself in front of 200 people. But like 5 guys went out there, they spun him around in circles, and then they said, go. And what did everybody do? Banged into it together, and everybody fell right over. Because by spinning around, you throw off your equilibrium and stuff like that. So, you know, but whatever. I thought it was pretty interesting. So atrial flutter, most of the times, okay, on a BLS level, is not going to be much you do, but if you're in the middle of nowhere, and you got to do it, you got to do what you got to do. So vagaling would be. Again, atrial fibrillation, the danger is 2 things, the emboli or clots that can develop, and the loss of the atrial kick. What is the loss of the atrial kick? The atrial kick, I don't know who thought of that term, is that we said that most of the blood that comes from the atrium to the ventricles comes by the AV valves opening. And then the last little bit after the valves open is that the atriums actually contract. Okay? So you get a little bit of blood coming down. So most of it, the valves open, blood starts falling, and then the atriums contract and push the rest of the blood out. Okay? So it's really, I mean, how long does this happen? Like a millisecond. I mean, the contracting is actually what starts to open the valves. Okay? But it's all, the whole thing, the whole spilling of blood from the atrium to the ventricles is in like a millisecond. You know, I mean, it's happened so quick. So again, danger will be the clots, but if your heart rate goes above 100, you're going to lose, okay, you're going to decrease ventricular filling time, and you've already lost the atrial kick, so you may be a little hypotensive, okay. SVT, okay, so this is different from sinus tachycardia because we said sinus tachycardia is usually explainable, right? Can it look a lot alike? Yes, it depends on how fast the sinus tach is versus how slow the SVT is, because you're just talking a slight difference in numbers. But the problem here is that when the heart rate starts to go real fast, it's hard to see all the different parts to it, the P waves and everything like that. Okay. Okay. So any questions on those rhythms? I think what we'll do on the next class is maybe we'll start out with just putting a whole bunch of rhythms and work our way through them, so we could kind of diagnose it. Okay, we got one last thing and then we'll be done. We'll do the junctional rhythms, and then next class we'll do all the dangerous stuff. And remind me before we leave, we should pick a date. The problem is that 2 Tuesdays from now is my little son's birthday, so I don't think my wife is going to be in a great mood if I come teach that night. So we'll have to figure out a different date to do it. Okay, so junctional rhythms are not happening in the top of the atrium, are happening down towards the AV junction, right, which is a little below the AV node, a little above the bundle of His. So that little space between the AV node and above the bundle of His is called junctional rhythms. Okay, so we're looking at basically kind of down right in here. Okay, right above the bundle of His, right under the junction. So this whole area in here is kind of called the junction. Okay. So we said the intrinsic pace rate in that someplace between 40 to 60. Okay. So in junctional rhythms, the P wave can be absent, inverted, okay, but it should not be normal. So this normal P wave should not be there. That's actually incorrect. So let's go back for a second, and what's going to happen? So if this fires, this area in here is what fires, nothing up here. If the impulse only goes this way, are you going to see a P wave? No. If the impulse goes like this, both ways, what are you going to have? Inverted P wave and then a QRS. Okay? If the impulse goes this way first and then this way, what are you going to get? P wave after the QRS. In other words, if it goes down first, then goes up, doesn't do it simultaneously, then you're going to get a P wave that's hidden in the QRS. Hidden or after the QRS. So very rare.
Yeah, I can see because it's inverted also.
Right. Very rare. Okay, I think I might have a picture of one. If not, I'll put a picture of one, but very rare that you're going to see that. Okay, so a junctional rhythm is a little more serious, okay, than any of the atrial rhythms, because we're saying now that the atrium, the SA node, is no longer the dominant pacemaker, and the junction, which is an escape pacemaker, has now stepped up to the plate and is firing. If the junction didn't, then what would be our next pacemaker site? The ventricles, right? So we're really now, we lost number one, we're up to number two, there's only three. So this is a little more serious, okay? So let's look at what we have, in this situation. So the first one we're talking about is a premature junctional complex. So we already had a PAC, premature atrial contraction. So that's an earlier than normal beat, but it's got a P wave. The P wave is going to look a little different. Why? Because it's not the normal site that's firing, it's someplace in the atrium. This is a premature junctional contraction. So here, there's going to be what? No P wave, inverted P wave, okay, or P wave after the QRS. That's what basically you're going to see. So you got normal, normal, early, and no P wave, right? So this would be a PJC. Okay. If this was here with a P wave, this would be a PAC. If this was here without a P wave and it was wide, it would be a PVC, premature ventricular contraction. Why do we call it ventricular? Because it's wide, right? That's why we would call it ventricular. But this one is a PJC, okay? And then we have normal, 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 PJC, okay? That reset, normal, normal, normal. So again, if these conduct, the heart rate is going to be 3, 6, 80. If these don't conduct, the heart rate is going to be 60. PACs, 99% of the time conduct. PJCs, 99% of the time conduct. It's PVCs where sometimes they do not conduct, okay? But most of the times these will conduct, so you don't have to worry about it. But if this patient says they feel really weak and tired and have a low blood pressure, and you're only looking at the heart rate on this, you're missing the picture. That's why I said to you, you have to feel for a pulse. Because if you're looking at this, you're saying, well, it can't be that they're weak and dizzy from bradycardia because their heart rate's 80. But if you felt the pulse and you only felt the pulse is 50, then you know why they're weak and dizzy. Okay? Okay, out of all the premature beats, PJCs are the least common. PAC is probably the most common, then PVCs, then PJCs. Okay? Again, an isolated PJC every so often, no big deal. I mean, you could be sitting here bored out of your mind listening to me and have a PJC, and stuff like that. It means nothing. Okay? We'll put another reason why. It could just be sheer boredom, right? And stuff like that. Okay? So again, a PJC is not a rhythm. It's an extra beat that's on some other rhythm. So this would actually be what? This would be a sinus rhythm with a PJC, right? If there were no P waves, this would be a junctional rhythm with a PJC. So it really depends on whether or not you saw P waves or not. Okay, so a junctional escape rhythm is when we say it's an emergency backup for the AV node failing. So let's look at this. So here, what do we have? We have a rhythm of about 50-ish, okay, with inverted P waves. So right off the bat, this is telling us what? SA node failed, atrial tissue failed, and what took over, what stepped up to the plate? The AV junction. So if this failed, okay, then it would be a wide rhythm at a rate of 20 to 40 because it would be the ventricles. If the ventricles failed on top of everything, you would have flatline and the patient would be dead. Very rare to happen, okay, but it could happen. So can everybody make out? Only thing that's different from a sinus bradycardia is what? Inverted P waves. So this would be, if these P waves flip the other way, this would be a sinus bradycardia, right? Upright P waves, normal QRS, okay? Maybe actually a little bit of a widened QRS, but somewhat normal QRS, okay? Everything else is pretty normal. The only thing that's different is the inverted P waves are only telling us one thing, which is what? The site of the pacemaker. So instead of it being sinus or atrial, it's junctional. That's all it's telling us.
It wasn't escape, it wasn't that junctional bradycardia.
You could call it, but it's considered an escape rhythm. There's no reason a junction should say, screw you atrium, I'm going to start taking over now, right? Because that's not its role. Its role is to only be there if it needs to be there. So that's why it's always called an escape rhythm. So it never happened on its own unless the atrium shut down, the SA node shut down. So that's the only reason why it would fire. Okay? So that's it. I mean, it's usually pretty easy to pick up on if the P waves are pretty prominent. Okay? Somebody, I think you showed me one before where the stylus on the paper was pretty light, so it was hard to see it. The paper was faded. Okay? And the complexes were not that high, right? The complexes were not that, the amplitude were not that high. So that could be, again, that the person's older, they're not just generating enough electricity, maybe the electrodes were not so clear. So the ease of making an interpretation is really based on the quality of the tracing you get. And the quality of the tracing we get EMS is bad. Remember, if you really want a good tracing, you got to rough up the skin, which means you got to buy the more expensive electrodes that have sandpaper on the back. And you got to actually rough up the skin. You can't put it over hair. Okay, you got to make sure they're fresh. We don't do that. But if you really wanted a quality tracing, you would have to do all those steps. Okay, what do you think the difference between a junctional escape rhythm and an accelerated junctional rhythm is? How fast it is, right? Accelerated means fast. So what would be the intrinsic rate of a junctional rhythm? Okay, we said 40 to 60. So an accelerated rhythm would be faster than 60. If it's over 100, it would be called, instead of accelerated junctional rhythm, it would be called a junctional tachycardia, right? So tachycardia is always a rate above 100. So the difference from all these different rhythms right now that we're going to talk about is how fast they're beating. Obviously, the slower they are, the more symptomatic the patient can be. So if you had this at a heart rate of 40, they'd be more symptomatic than if you had a rate of 60. If you have, the other one, wherever it went to, if you just have a heart rate of 180, they're going to be more symptomatic because of the decreased ventricular filling time. Now, how is it possible that a junctional rhythm that has an intrinsic rate of 40 to 60 could go at 180? Stuff happens, right? This is where you have those reentry phenomenons and that thing go out of control, right? I mean, there's no 100% in the body. So should it happen? No. Does it happen? Yes, once in a while where it'll go out of control. Okay, so all an accelerated junctional rhythm is no P waves. So here we don't even have an inverted P waves. We have no P waves. And the rate is faster than a normal junctional rhythm, which is 40 to 60. So this rate's going to be between 60 and 100. Okay?
And an escape rhythm always have P waves converted?
No.
And have no P waves?
Yep. It's a junctional rhythm, so it could have no P waves. Right? Any junctional rhythm could have no P waves. Is the patient going to call you if they're in this rhythm? No. 1, 2, 3, 4, 5, 6, 70. Heart rate is 70. This is going to be found anecdotally for some other reason. That this patient got an EKG for some other reason. In other words, they called you because they were dehydrated. They called you because, I don't know, and you just happened to put the EKG machine on them, and you saw this rhythm, and you're like, I don't see any P waves. And you're going to do a 12 lead, and you're not going to see any P waves in any of the leads. You're going to say, the doctor ever say you have anything wrong with your heart? He's like, no. And it just, patient's probably totally asymptomatic, because this is a normal heart rate. The only thing that's different from a normal sinus rhythm is the site of the pacemaker. That's all it is. Obviously, this is not a patient where you could say stay home, because they're down to their backup pacemaker. Now, if this fails, they're going to go real slow. So they need to find out why this is happening. Okay? So junctional tachycardias, again, are going to be a rate of 100 to 180. Paroxysmal rhythms, sudden onset, sudden stop. Are you going to be able to tell the difference between SVT? No, because you can't see a P wave in SVT anyway. So it's very hard to tell the difference. It's just going to be a fast rhythm. Everything's going to be mushed together, and you're not going to be able to see it. Okay, well, I don't know if this is really tachycardia, but let's see. 1, 2, 3, 4, 5, 6, 7, 8. Okay, so they made it exactly at 100. Okay, so here you could see it. Now, the question I would have right off the bat is this a P wave after the QRS? Right?
Inverted T wave.
Well, it's not an inverted T wave, because here's the T wave. Here's the T wave. So again, it's one little rhythm strip. It's not a 12 lead. We're not looking at it multiple times. We can't say right off the bat. But the thing that strikes me just looking at it real quick is, is that an inverted P wave, or is that a P wave after the QRS? And again, is this the P wave? This little notch up here? Is this it? Who knows? But that's just something that's striking me, because there's clearly no P wave in front of it, which is why we're going to call it a junctional tachycardia. But could it be that the P wave is happening afterwards? Could be, But like I said, you wouldn't make that diagnosis just based on 6 seconds of a strip. Okay? So, any significance of a PJC in itself? No. Premature junctional contraction, no big deal. unless they're happening. You could have the same thing. Remember we had the terms bigeminy and trigeminy. You could have one infrequently happening every 30 seconds, no big deal. You could have one normal beat, one PJC, that would be bigeminy. Two normal beats, one PJC would be trigeminy. That's a little more concerning. It's most concerning when you have premature beats and they do not conduct. Because if they don't conduct and make a mechanical contraction, then the heart rate slows down. So it'll be symptomatic. It's not the complex, it's the fact that they don't actually contract and make a mechanical contraction that makes them more serious. Okay? A junctional escape rhythm, the only reason we're really concerned about it is it may be slow, and the fact that the SA node and the atrium are not the dominant pacemakers anymore. So we're just concerned, why did that happen? So it's a matter of how the patient's tolerating it. Okay, most of the times they tolerate it fine. If the heart rate is, below 50, 40 to 50, they may not tolerate it. Okay, accelerated junctional rhythm, usually there the heart rate is in the normal range, 60 to 100, so they usually tolerate this fine. Okay, no big deal there. And then junctional tachycardia is where the rate is over 100. It could go upwards of, close to 200. And they're going to complain of palpitations. You're not going to be able to tell the difference unless it was that one particular one that was up there was right at 100. Because once you start getting over 150, everything's mushed together. You're not going to be able to tell the difference with it. So this would get treated the same way SVT would, which would be if it's real unstable, electrocardioversion. If it's mildly unstable, you'd probably try some adenosine or some cardizem. Okay, so any questions on any of the rhythms we went over tonight? Okay, so next week we're going to do the heart blocks and the ventricular rhythms, and maybe we'll look at like 1 12 lead of each type of heart attack and point that out. Okay? Now,